today's topic for the Lunch and Learn is bladder health and women's health. For those of you that don't know me, I am Becci Baker. I'm one of the physical therapists here in our PT department. I have been doing women's health for almost a year now. So I'm going to give you some information on what that entails and how it might benefit you. So do you find that you always go to the bathroom before you leave the house? Maybe you go once you reach your destination, you know, just in case. How about when you cough, laugh, sneeze? Do you leak a little bit? These scenarios may have become the norm for you, but having these bladder habits and or behaviors are far from normal. This is where women's health physical therapy could benefit you or someone you know. So today we'll discuss the definition of women's health PT, some signs or symptoms that might indicate you could benefit from receiving physical therapy treatment for your diagnoses, and then a little sneak peek into what PT treatment for some of these common diagnoses might include. So women's health is thought by Herman and Wallace, the Pelvic Rehab Institute, to be a non-surgical approach to rehab of dysfunctions in the pelvis that contribute to bowel, bladder, sexual health, and pain complaints. Approaches might include behavioral strategies, manual therapy, which is also like massage, modalities, therapeutic exercise, a lot of education, and functional retraining. So some signs and or symptoms that you might be experiencing, like the woman in the picture, running or rushing to the bathroom. So go ahead, Star. Some of the signs and symptoms are incontinence or voiding dysfunction, pelvic pain, prolapse, sexual dysfunction, or it's not necessarily a sign or a symptom, but establishing a baseline for exercise program for the pelvic floor muscles is just as important to go to PT for that, and I'll touch a little more on that later on. So incontinence or voiding dysfunction, who suffers from these diagnoses? So 25% of young women, 44 to 57% of middle-aged women and postmenopausal, and then 75% of older women in nursing homes. There are also statistics that demonstrate urinary incontinence and its place with women who exercise. So they did a questionnaire and administered it to 290 women who regularly exercise, and they found that 47%, or almost half of that group, admitted that they had an incidence of incontinence while they were exercising. So incontinence or voiding dysfunction can fall into these four different categories. So continence is the voluntary control of the bowel and the bladder. So in order to be continent, you must have an intact central and peripheral nervous system. It also requires intact cognitive function. So that can become kind of tricky for that 75% of women in nursing home if they suffer from things such as Alzheimer's or dementia. So incontinence is then the loss of control of the bowels and or bladder. It's not itself considered a disease, but they actually look at it as more of a symptom of a dysfunction that you have. So it can be in the form of urge incontinence. So if someone has ever told you that you have that or you have these symptoms, chances are you fall into this category. So urge incontinence is where they complain of the involuntary loss of urine accompanied by or immediately preceded by urgency. So the strong desire to void. So there's typical triggers for urge incontinence, such as like cold temperatures. Some people find that that can be a trigger, that they feel their bladder is irritated and they are going to the bathroom more frequently. Running water is definitely one. So I'll have women tell me that while they're doing the dishes, they all of a sudden get the urge to go to the bathroom, and if they don't go, they will leak a little bit. Putting a key in the door. So you get home and your typical habit is to go to the restroom right when you get home, so the act of putting the key in the door triggers your brain to think that it needs to go to the restroom. Urge, I'll touch on that a little bit more with the mixed. So stress incontinence is the involuntary loss of urine with physical exertion. So these are things like coughing, laughing, sneezing. They call this the knack. So if you have a little bit of leakage with the knack, chances are you have more of stress incontinence. So stress incontinence is a true issue of pelvic floor muscle strength.
What about trampolines?
Yes. I had a woman that said she jumps on the trampoline and she dribbles a little
Yeah.
bit every single time.
Yeah, I never have, so I was on a trampoline and I was
Yep.
like, oh my gosh.
Yep. Or while you're working out, like that group that said they have some incontinence while they're working out.
That's
Chances are it's
stress.
more stress.
Okay.
Yes. So you're doing something and then it's causing the incontinence. A lot of times people find that it's more when they're like in an upright position or seated because you have all of your organs putting pressure down on your pelvic floor area, including your bladder. So people that have stress a lot of times have had some kind of like a major surgery, a baby, several babies. They had trauma to their pelvic floor area causing like some kind of a laceration, so then they have some scarring. Those kinds of things can lead you to have stress. And I never really discussed it with urge, but a lot of times they find that people that have urge incontinence, it's more of a behavioral thing. The advantage being, if we can change the behaviors, a lot of people will see a remarkable change in their incontinence. So it's more of a brain bladder connection issue as opposed to a strengthening problem. However, you can have mixed incontinence, which is a combination of urge and stress. So people will oftentimes come in and say that they leak a little bit when they have their knack, like they cough, laugh, sneeze, jump, and they also feel like they're constantly running to the bathroom, and if they don't rush to the bathroom, they will have a little bit of leakage. So bowel incontinence is also an issue. It's not addressed as much with the training that I received for women's health PT. You know, there's different levels, so you can get more trained in the bowel disorders. However, people do find that if we address these three incontinent issues, their bowel problems also tend to improve. I had a patient who struggled with both, and without addressing the bowel disorder, we were treating her symptoms with the incontinence of urine, working on strengthening, also some restrictions that she had in that area, and she had almost zero issues with her bowels following her treatment and therapy. So another one that I didn't list is you can have nocturia, which is some incontinence or issues with your bladder in the nighttime. Or some people also view it as the need to frequently go to the restroom throughout the night. So I'll have people come in and say that they're waking up 3, sometimes 4 times a night to go to the bathroom. And then, you know, it kind of leads into a sequelae of questions. Well, when you do get up, do you feel like you have to go a lot? And they say, well, no, not really. Okay, so are you creating a habit, a behavioral issue? So that's definitely addressable with just some behavioral changes, because they technically say if you're watching the amount of fluids you consume after a certain point in the evening, and if your medications aren't, you know, like a lot of diuretics and those kinds of things, you truly shouldn't have to go to the bathroom in the middle of the night. So I'll address it a little bit in the treatment, but while I'm talking about it, because it's not as much of a topic that I addressed in today's lecture, they say that if you wake up and you, in the middle of the night, and you're like, oh, I have to go to the bathroom, you're supposed to boss yourself and your bladder and say, no, you don't have to go to the bathroom, and just work on falling back to sleep. And yeah, so it's remarkable. I had a patient, she had the same face. She's like, how am I going to do that? So she, after our first treatment together, went home and then came back a week later, and I kind of asked her, you know, did you work on these behavioral changes? And she said, I learned something about myself. And I said, well, what was that? And she said, that I don't have to go to the bathroom in the middle of the night. She said, I woke up a couple times and I would just tell myself, nope, you don't have to go, and go back to sleep. And then she would get up in the morning and go as she normally would. So there's something you can practice.
Is that good for you?
Yeah, as long as, like I said, I mean, you know, if you're having to get up one time because maybe you drank some fluids later in the evening, fine. But the second time you wake up, you should definitely tell yourself, like, nope, I don't need to go to the bathroom. Because the concern is if you're frequently using the restroom and your bladder is not completely full, your bladder starts to think that it can only hold a certain capacity. So then it will reach that capacity next time and you'll say, oh, I have to go to the bathroom. So it's like that connection between your mind and your bladder, even though your bladder has a larger capacity that can hold. So that's where we work on the retraining part of frequently going to the restroom. So they say that on average you should be going to the restroom, depending on how much fluids you're drinking, anywhere from every 2 to 3 hours. So I had a lady that works in the schools, and so she said she was going to the restroom in between every single class period. So let's say roughly every 50 minutes. She just felt like if she didn't go, she would get in the middle of the next class and have to go at that point. So we said, well, let's work on stretching that to every 2 class periods. So she did, and she said, you know, I didn't realize that I was going to the bathroom when my bladder wasn't completely full. So she retrained her mind to realize that she doesn't have to go that frequently. She was just doing it on a just-in-case basis. So that's where these guys were saying. They talk about, you know, are you using the restroom because your bladder is full, or are you just in case going to the bathroom because you think, well, if I don't go now, will I have an opportunity later? So we form bad habits of our bladder in that way. So that's one of the biggest diagnoses, by the way, that I see or have had come through the department is incontinence. And we've had a really good success rate so far. Most women have seen a remarkable change in their symptoms with PT for those problems. So pelvic pain is another topic or diagnosis symptom that people are coming to physical therapy for. It's thought to be pain in the abdomen or pelvis not caused by disease. So some common things, I don't know if you've ever heard the term dyspareunia. It actually means difficult or painful sexual intercourse. So having pain while you're engaging in that activity. Once again, not normal, but people find that it kind of becomes their norm. So they think, well, it's just always been painful, so I just figured that's how it was supposed to be. I actually read a book on returning to activity following childbirth, and the lady spoke to the effect that she had a baby, and that was afterwards when her and her husband tried to re-engage in that activity, it was always painful, so it became a really huge stress on their marriage, and she ended up getting divorced. They ended up getting divorced, you know, because it just caused such a strain for them. And she decided that she just didn't want to live that way anymore, so she sought out help and then ended up becoming a women's health physical therapist because she realized that, you know, she didn't have to live that way and she wanted to help other people realize that they don't. But for certain reasons, you know, scar tissue, those kinds of things, people do end up with pain. And it might not even just be with that activity, you know, it might be you have your well woman exam and they want to use a speculum and you just can't even tolerate the insertion of that. Well, that becomes a problem for other health related issues. So I'll have people ask, well, will insurance cover that? Well, yes, as long as we kind of word it the correct way that, you know, we're not only addressing it from an issue of, you know, quality of life with your spouse, but, you know, also important that you're able to tolerate the insertion of a speculum to have those well woman exams, because that could be a concern for medical reasons if you're avoiding that because it's painful. So common conditions that I've also seen and we've had come through our PT department, and the assistants and Sandra have been good about picking up on, is if someone comes in for like low back pain or like pain in their groin or hip or SI joint, it can actually be related to your pelvic floor. So it's just an avenue that we kind of have a little better eye on. So if people are having those pain complaints, then you kind of work into those questions of, well, do you find yourself frequently going to the restroom or leaking? If you do, cough, laugh, sneeze, are you having any pain with intercourse, those kinds of things. And then, you actually might find that by doing treatment to the pelvic floor area, the back pain improves. So it's just kind of that referral pattern of all those things are kind of in the same area. So, and really quick before I touch on Prolapse, just so you guys know, the course that I did go to touches some on treating patients that have been like sexually abused or had a trauma to their pelvic floor area for other reasons. It becomes kind of one of those interdisciplinary things where we would work with the physician and maybe like a psychologist or a mental health counselor in conjunction with them while we're treating that patient, but it is something that we can help improve their quality of life as well, because a lot of those people become afraid to have anything placed in that area, like a speculum or those kinds of things, so helping them work through that to improve those things. So prolapse, the feeling of the bladder or other tissues in the pelvic area falling out would be the definition of prolapse. Some people will find that they have these symptoms the most when they have a bowel movement, because you're bearing down, and then that's when those tissues are essentially exiting the vaginal area. So if you find that you have these symptoms, we can also help address that with some strengthening. So the other thing to keep in mind with prolapse is that sometimes the symptoms can also present itself like the pelvic pain with like a low backache or some pressure in your pelvic floor area. So you can have like a grade 1, which would be very, very minor prolapse, and not have a complete falling out of like your bladder. So if you feel like you're having symptoms related to this topic, just talk to your primary physician, and then they can kind of clue into if that is the case. They'll do an assessment, and then you can refer on to PT. So sexual dysfunction, I guess I did kind of touch on this, can be related to a trauma and or abuse that occurred to the pelvic floor area, causing pain or dysfunction with intercourse. You can also think of trauma as childbirth. For those of you that have had kids, I mean, that's can be a traumatic experience for your pelvic floor. Some people can have tearing up to like a grade 4 tear, and then you have to have sutures in that area. Anytime you have some kind of tearing or sutures, or really just an expansion of like tissue such as the birth canal, you can have risk of scar tissue, which then can become a problem for other reasons. So we don't go into depth as much on the abuse side of things, but like I said, PT can help those people as well. So a baseline for the exercise program, the reason I add that in the presentation is that it's not recommended that you perform a Kegel exercise without having an evaluation from a women's health physical therapist or your physician. The reason being is, although you might think that your leakage or incontinence is coming from weakness in your pelvic floor, you can actually have too much muscle tone, and then they say that the bladder kind of dribbles outside of those tight muscles. So you might be thinking you need to strengthen, but in all actuality you actually need to work on relaxing those muscles, or essentially like stretching instead. And so if you start doing a bunch of Kegel exercises when really you're already too strong in your pelvic floor, it's like you're kind of adding insult to injury. So there's also been a few people that I have that they're like, oh yeah, I've been doing Kegels. My doctor said to do Kegels. I've been working on them. I do X amount per day, and then I do an assessment of their pelvic floor and say, okay, now let's test your strength of those pelvic floor muscles, and they don't have really any contraction. I'm like, okay, so are you contracting? And they're like, yep, I'm doing my Kegel. And I'm like, well, actually you're squeezing your butt cheeks together and your thigh muscles are being squeezed, but the pelvic floor is having really no action. So that's where it becomes concerning is people think they're performing a Kegel when really they're performing what we would call like a glute set, so then they're still not addressing their issue. So they're thinking, I've been performing these Kegels all day long and my leakage and incontinence isn't getting any better. So some diagnoses, we've definitely touched on most of these. Urinary incontinence is a huge one. Some pain in the pelvic floor. Constipation can also be something that we treat with physical therapy. If you have that as a chronic issue for yourself, it can actually be putting more pressure on the bladder and then more pressure on the pelvic floor area, so it kind of becomes a vicious cycle. So it's also something I've addressed with people. So as opposed to the bowel incontinence, you can also be constipated, and then we can discuss some ways to fix that as well. Vulvodynia, which would just be like pain in your pelvic floor area. Muscle spasms, even if that's not in your pelvic floor, let's say that's in your buttock area, your low back, you know, like I said, it might be coming from the pelvic floor. Low back pain, groin pain, an old laceration in the pelvic floor, and then a scar that's otherwise painful. So I don't know if you know anyone that's had a C-section, but a lot of moms that have C-sections discuss that they have such pain in their scar, kind of in their low abdomen area. And then that becomes an issue for a lot of things. You know, if you have pain in your low abdomen area, you don't want to maybe bear down as hard, or coughing might be painful. So we can also address that. It doesn't always have to be directly related to the pelvic floor itself. It can be postpartum type issues or otherwise. So if you've had a hysterectomy and they also do a scar kind of down low, that could be also something we work on.
Really any abdominal surgery,
Yeah.
right?
Yeah. So they talk about women's health being, you know, a lot to do with the pelvic floor, but it's also a lot of working on like your core support and mobility through your abdomen. I didn't really recognize this till I had the training, but they look at kind of, you know, are you having restrictions through your abdominal wall? So there's ways that we can assess that, because then that might impede on other things like deep breathing, that kind of stuff. So treatment, women of most ages can benefit from women's health. They do say that if you have never had a pelvic floor exam before, like someone that would possibly be like under the age of, I'm not sure, I think the recommendation now is like getting to be older, but most people have their first exam when they're like in high school, let's say. You would want to have that pelvic floor exam performed by your primary before you would come to PT. But for most of us that are older and above that, where we've had several, you know, pap smears before, if you see your primary and you're discussing these issues, just let them know that you feel like you might benefit from PT. So through the lifespan, women who suffer from the pelvic floor related diagnoses, and more often than not, they don't seek out help. Some treatment strategies that can be implemented, like for urge incontinence, so where you feel like you're constantly rushing to the bathroom, they say you have to work on behavioral training. You can also use medication, but some people don't really like to have another med that they're taking during their day. So that's a big thing we focus on. And behavioral strategies are things like working to increase the time between which you're going to the bathroom. They say that ideally, if you go to the bathroom, if you count in seconds, like 1 Mississippi, 2 Mississippi, you should be going for at least 8 seconds or greater. If you're going less than 8 seconds, chances are you're possibly just in case peeing. So you're peeing before your bladder is completely full. So that's something you can look at. If that 8-second period is less when you're going to the restroom, then you can work on increasing the time. Stress incontinence, so where you're having a little bit of leakage, that needs a lot of exercise is how we'll address that. Once again, you can use some medication, but some people find that, you know, it gives them dry mouth, or they don't really want to have to take another med. A mixed incontinence is a combination of treatment from the urge and the stress, so behavioral and exercise. Pelvic pain, we do a combination of manual therapy, which would be some massage internally to the pelvic floor area, biofeedback training, and then also exercise. So exercise doesn't have to necessarily be strengthening, it can also be relaxation. So that's where we work on getting the tone decreased in the pelvic floor area. And then prolapse, therapeutic exercise can be beneficial in retraining the bladder. Depending on the severity of your prolapse, you still might have to consider surgery to address that, but then keeping in mind that even if you had surgery, you could still benefit from PT afterwards. So then kind of begs the question, well, now what do you do? So if you are someone that feels like this stuff all applies to you, or you know someone that it does, you know, you could contact one of us in the PT department to set up an evaluation. But things to keep in mind if you are ready to have some treatment for your women's health related issue is you'd want to make sure you're up to date on your well woman exam. So go see your primary physician and take care of that and discuss these issues with them. And then get a referral from them, so they would just write you an order for physical therapy, and then you can just call our department to schedule. So I'm here 3 days a week. But in the near future, we're going to be adding one of the assistants to also do some of the women's health physical therapy, and she's here on the days I'm not. So we would have coverage for 5 days a week to address those needs. So, questions? Kind of information overload, but
That was great.
yes.
How many days a week is therapy for that?
So it can vary. Like one patient I have right now, I started her on a program, but hers is more working on strengthening, and since we can't really see a large change in strength like that, she's actually coming once every 2 weeks. And then I have another patient that's coming in for more pain in her pelvic floor area, and we're working on a lot of relaxation and behavioral training, and she's coming once a week right now, just so we can continue to address those things. I've also had patients come twice a week for a period of time, but it's nice because we can kind of see what the issue is first, and a lot of it becomes homework on like your part. So working on that at home and then coming back in to kind of check in and make some adjustments as needed. Cool. And we do have pamphlets, so if you know someone that's kind of considering it, but you are like, well, she said all this stuff and I don't remember what y'all said, it's kind of touched on in the pamphlet as well. Cool. Thank you guys.
Good job, Becky.